I would like to welcome you to our inaugural Interdisciplinary Health Data Competition webinar. I'm Humera, and I have really amazing guests here with me who will share with you some data set that they have been working together. So a little bit of an introduction. I'm Humera. I am an associate professor here at the Carlson School in the Finance Department. I'm also the academic director of the Medical Industry Leadership Institute, or what we call our MILI. And this is, before I go any further, this is an interdisciplinary health data competition, and we have a lot of input from different departments and different groups who inputted into the conceptualization and sort of the framing of the entire thing. So I'll tell you a little bit about the competition itself, but before I do that, I would like to introduce you Stefan Gildemeister and Erin Sanstedt. They're both from the Minnesota Department of Health's Health Economics program, and I will let them introduce themselves, but I just want to welcome you guys here and thank you for bringing this opportunity to us, to the University of Minnesota. I know we work really hard on this data, and we're all very excited about the impact of this data to research community, business, and policy community in general in Minnesota. So we're very grateful to be, as a group at the university, to have our first sort of peek at this data too. So Stefan, do you want to introduce yourself?
Yeah, good afternoon. My name is Stefan Gildemeister. I direct the Health Economics program in the Department of Health, where we do research and policy analysis to inform healthcare policymaking in Minnesota. And our work generally is empirically driven. We draw on a number of data sources, and one of it is the claims database, which I'll talk about more in a moment. All right.
My name is Erin Sanstedt. I'm a research scientist in the Health Economics program. I work primarily with the Minnesota All-Payer Claims Database.
Well, thank you so much. So let me say a little bit about the competition. We have our main goal with this competition is to really gather an interdisciplinary community at the University of Minnesota who are interested in data. They're interested in using real-world health data to address some of the big challenges we have in this sector. We also wanted our students to get a chance to look at innovative solutions and create some of these solutions using some of the data techniques and statistics and other data tools you may have. And we want our students to really showcase their understanding of these real-world health problems and create some solutions. You will hear about the data, and this webinar is not about sort of releasing the challenge, but because that is going to come at a later date. However, you will hear a lot about the data that you will be using in this challenge in this webinar. And I will also say that the entire data competition is going to be an exploratory analysis. So we're not going to pose a particular question for you. So after this webinar, please feel free to sort of explore within your teams of some of the topics that may be interest to you. After you hear about the data, you will have a better sense of what are some of the questions you can answer and explore. But these are some of the example topics. By no means they're not inclusive. So there's a lot of room for creating creativity and new topics here. But some of the topics that could be of interest are trends in drug treatments, including cost of utilizations, and in particular for certain populations or locations or location types or payer types. Understanding some of the changes over time and identify areas in need of innovation related to prescription drugs. Looking at cost drivers, as you heard here every day, prescription drug cost growth is a major policy issue, and think about some policy changes and interventions that will help lower prescription drug costs. Another area where you could look at is uptake of new drug treatments and trends and prescription rate of some of these new drugs that come to market and impact on the cost of alternatives. And yet another idea that we'll just throw out there is topics around drug safety and responses to utilization. For example, FDA communications, safety communications, black box warnings, and other recalls, and how does the market respond? How does utilization trends respond to some of those important safety challenges. We're trying to, this is our very first time doing the competition, so we're trying to be very nimble about the rules and the requirements, but a few things we want to highlight is this competition is open to all graduate and professional degree-seeking students at the University of Minnesota Twin Cities. We would like a maximum of 5 students per team, and one important thing is that it is interdisciplinary, so we would like to have students from at least 2 different colleges or schools, departments within the university. We want you to meet new folks, make new friends, and work with people with maybe you wouldn't work otherwise. Individual students may only participate on one team. If you don't have a team yourself, you are welcome to form your own team and apply as a team. But you can always register on your own as an individual, and we will make sure to put you on a team. So that's the teams. Some of the competition requirements that you will basically do is the first phase of it is going to be, you will be submitting a 1-page executive summary together with a PowerPoint presentation outlining your team's project. We require a maximum of 20 slides there. And together with it, with your presentation, you will submit a voice recording of your analysis, insights, and innovations. It's a nice way for the judges to see not just your presentation, but also the voiceover of your team. And then the finalists will present projects to the judges. And again, there will be a 20-minute presentation time followed by judging. And we will provide a rubric, judging rubric on March 18, which is when we will be releasing the data. We have awards. First place team gets $4,000, second place $2,000, and third place team gets $1,000. Some of the important dates to consider, the biggest important day at this point is March 12, which is the last day to register to participate in the competition. We will be putting teams together if you are not submitting as a team. And March 18, we have a kickoff event, which is at the Carlson School, evening 5 to 6:30. We'll have some fun, meet with each other, and it's your opportunity to meet other teams, meet other students, and ask them questions. Projects will be submitted by April 3rd. This is the voice thread supplemented presentations in the executive summary. Finalists will be judges, so April 3rd to 8th is going to be a busy time for the first round judges, and then we make sure that there's a chance you will be a finalist, so block April 9 for finalist presentations on the award ceremony. I would love to acknowledge our steering committee. As I said, this is a competition that represents interdisciplinary faculty. We have Steve Johnson from Institute for Health Informatics, Helen Parsons from the School of Public Health, Division of Health Policy and Management, Dao Liu, who's at the Carlson School of Management, Information and Decision Sciences, Caitlin Carroll from School of Public Health, Health Policy and Management, Joel Farley in the College of Pharmacy, Ashwini Sankar with the Medical Industry Leadership Institute, Russell Funk, who's at the Carlson School Strategic Management Entrepreneurship Group, and Kim Choi, who is the Carlson School of Management MILI Program Administrator, who has done an amazing job and put in countless hours for this competition. So we thank all of them, and we also thank our partners and sponsors. Again, this is a collaboration between Carlson School, College of Pharmacy, Institute for Health Informatics, School of Public Health, and MILI, and we have funding from United Health Foundation I would like to acknowledge. And of course, we could not do it without Minnesota Department of Health and the Minnesota All-Payer Claims Data support. So with that, I will leave the presentation to Stefan so that he can tell us about their unique data.
So I just have a few words of introduction, and then Aaron will sort of bring you a little closer to the data. But before I start, I just wanted to say that I'm really excited on behalf of the health department to be part of this initiative. I'm really thrilled to sort of see what comes out of the competition. I'm excited that this opportunity exists within the Carlson School to bring students closer to some real policy challenges. So that you're not just operating in a sort of academic setting, but that you are looking to see what you can learn about real world challenges, in this case related to prescription drug policy. This is new data, so we are excited that we can see this competition with this data, sort of see what you make of it. I expect we'll be learning something from your work. We haven't formally talked about this, but if there's some really helpful results that are coming from the analysis, we'd be happy to sort of put them together, maybe into a little fact sheet or an issue brief that we can release on our website and maybe share with the university. So all of this is really, really exciting, and we're thankful and encouraged that we're part of it. So with that, just a couple of words where the data come from and why we at the health department have been making available or have been structuring this data that now will become available to this competition. No, the initiative is not entirely focused on the competition. It just happened that PNR was part of giving us feedback on our work, and from that grew sort of the idea of why not use the data for the competition. So the foundation of the public use file, which you will have the opportunity to work with, is the Minnesota All-Payer Claims Database. It's a repository of de-identified healthcare claims data from public and private payers in Minnesota. It was created as part of a legislative initiative in 2007 and 2008, a health reform initiative, the last big health reform initiative. And though the data is relatively well protected in Minnesota, because in Minnesota we are kind of concerned about use of data, the legislature also authorized us to put together public use files for users in the community, and we've done a number of things that I might highlight in a moment. So how this is maybe to give you a sense of what the data can be used for. How have we at the health department used the data over the past 5 years or so? Done some work on healthcare spending, looking at variation in hospital prices, looking at drivers underlying commercial spending. We've done some work on disease epidemiology, looking at cancer and hepatitis C drugs and use of those drugs. Together with Helen Parsons, by the way, looked at chronic disease and heart failure. We sort of looked at various pieces related to the healthcare market, children's healthcare use, telemedicine, and then also at a number of things related to prescription drug, including opioid prescribing patterns. And I'll skip the rest, take a look at the slide and see if you have questions, but the basic point is we have been recognizing the limits of releasing data broadly to the public. We have used the public use files as a strategy to generate value to a range of users, whether they're media, whether they're actuaries, whether they're the industry, to give you the ability to really identify some metrics across the whole market rather than for specific plans or specific providers. That is what the data is pretty powerful for. I'm clicking, but nothing happens. How about this? So what motivated this particular, the generation of this particular public use file? As Pinar has said, there's a ton of public policy angst about prescription drug prices and the affordability of prescription drug therapies in Minnesota and in the nation. In Minnesota, we spend about $4.5–5 billion on retail prescription drug spending. You add prescription drugs that are delivered or administered in medical settings, it's closer to $8 billion. So it's a sizable share of total spending, and in particular, an increasing share of spending. Policymakers are looking really urgently for ideas. Just in this session with a few days under our belt. There have been 5 or 6 bills that are trying to address various aspects of the challenges related to prescription drug prices and spending and access to drugs. But there is such opaqueness in the supply chain, and there are no easy solutions. So this, at least this is our hope, this public use file can become a tool to hear from a broad cross-section of the community on the basis of empirics what the legislature might do and how we might be able to identify potential solutions to the challenges while we wait for Congress and the federal administrations to move forward on their initiatives. So the public use files were aimed to be include information on drug characteristics, on members, and on the share of spending for health plans and individuals. And as I said, we're looking to crowdsource some ideas from folks like you. There are 2 public use files which are not yet available, but will become available with the release date. There's documentations with hands-on information for users and some metadata and context, and we'll also have a slide deck that is not all that different from what Aaron will produce in a moment, and all of that will be available for you on March 18th. And I'm handing this off to Aaron. He kind of no longer works.
So before we take a look at the PUF design, we have a few data considerations. Minnesota policymakers structured requirements for data submission under Minnesota APCD to focus on payers under its jurisdiction, and payers represent the primary volume of healthcare services in the state. As such, the Minnesota APCD was not designed to capture data from the Indian Health Service, VA, TRICARE, workers' compensation, dental claims, or uninsured individuals. Although the Minnesota APCD contains both medical and pharmacy claims, these PUFs are restricted to data from retail pharmacy claims for Minnesota residents. Prescription drugs administered in medical settings, such as hospitals, are not included in the PUFs. These drugs are generally billed in medical claims as opposed to pharmacy claims. Lastly, costs in the PUF represent healthcare transactions before any applicable rebates. So the PUF designs make use of the following drug classifications. The National Drug Code, or NDC, is a 3-segment universal product identifier. The first segment identifies the labeler or the manufacturer. The second segment is the product code, which identifies the strength, dosage form, and formulation of a drug. The third segment is the package code, which is not relevant to individual prescriptions. At a broader level than NDC is non-proprietary drug name. Drugs with the same active ingredients have the same non-proprietary name. Pharmacy claims in the Minnesota APCD include NDCs, which we use to link to reference data sets to obtain drug characteristics. We have 2 versions of Minnesota APCD prescription drug PUFs. A summary PUF is based on non-proprietary drug name, and a detailed PUF is based on NDC. So data in the summary PUF are aggregated by non-proprietary drug name and payer type. Payer type consists of 3 categories that are based on insurance product. The categories are commercial, Medicare, and Minnesota healthcare programs, which includes Minnesota Care and medical assistance. The summary PUF includes data on over 1,700 distinct drugs. In this PUF, we have demographic information on the distribution of scripts by member, age group, sex, and RUCA class. Demographic classifications are based on member information reported in pharmacy claims. Data in the detail PUF are aggregated by 2-segment NDC and payer type. As seen in the example here, a single non-proprietary drug can have multiple NDCs. The detail PUF has a higher level of granularity than the summary PUF and allows for comparison of drug products across manufacturers. There are over 11,000 distinct 2-segment NDCs in the detail PUF. In both the summary and detail PUFs, cell counts of less than 11 are redacted, as are provider counts of less than 5. Summary and detail PUFs contain 2012 and 2016 data, which appear on separate worksheets in the Excel files. The summary puff is derived from the detail puff, meaning the total prescription counts and costs are the same at both levels of aggregation. This slide shows prescription counts and costs broken down by payer type and prescription year. 2012 and 2016 puff data each contain over 55 million retail pharmacy prescriptions, totaling over $4.5 billion. Note that we see an increase in prescriptions from 2012 to 2016 in both the Medicare and Minnesota healthcare program categories, while there's a drop in the commercial category. Due to the Supreme Court ruling of Gobey versus Liberty Mutual, the Minnesota APCD experienced a loss of self-insured data. This loss should be considered when looking at total commercial counts for 2016 data. However, averages are not expected to be impacted by this decrease in volume. The puffs represent over 95% of pharmacy claims and their associated spending in the Minnesota APCD for 2012 and 2016. As previously mentioned, we used NDCs reported on pharmacy claims to link to pharmaceutical reference data. We obtained drug characteristics from the FDA National Drug Code Directory and Metaspan. Drug characteristic variables found in both the summary and detail puffs are non-proprietary, drug name, and therapeutic category. The remaining variables on the slide are in the detail puff only, as they're not applicable at the non-proprietary name level. Puff measures were calculated using data reported on pharmacy claims. Each puff record includes counts of unique members and prescriptions filled, as well as means, medians, and standard deviations for the following cost and supply variables: quantity dispensed, days supply, health plan paid amount, patient paid amount, and total amount. Patient paid amount is defined as the sum of deductible, copay, and coinsurance. Total paid amount is the sum of patient paid amount and health plan paid amount. Complete variable definitions can be found in the data dictionary for each puff, which appears in a separate worksheet in the Excel files. The puffs include a number of measures that can be used for ranking. While these measures are in both the summary and detail puffs, the summary puff also includes columns that show the numeric ranking for these measures compared to other records in the puff. The rankings are specific to payer type. Ranking measures include total cost, total prescriptions filled, cost per user, cost per prescription, percent change in cost per prescription from 2012 to 2016, cost per day supply, and cost per unit dispensed. This slide shows a subset of records and variables from the summary puff. The data can be easily sorted and filtered in Excel or pulled into statistical software such as SAS or Stata. Notice that each non-proprietary drug name shown here appears in 3 rows, 1 row each for commercial, Medicare, and Minnesota healthcare programs. To look at statewide estimates, users must combine data across payers. Also note that a member may contribute to more than 1 row if they have multiple prescriptions. We've prepared 2 use cases to illustrate ways in which the puffs could be used. This graph shows 2016 insulin list pro data from the summary puff. The first set of bars shows mean day supply. The second set of bars shows insurer paid mean, and the third set shows member paid mean. We see that commercial insurers on average pay more per insulin lispro prescription than do Medicare and Minnesota healthcare programs, but individuals on Medicare have a higher average patient responsibility. Insulin lispro prescriptions in Minnesota healthcare programs tend to have a lower days supply. Our second use case looks at the 5-year cost per prescription change in Humera. Humera is a brand name drug that's used to treat inflammatory conditions such as rheumatoid arthritis. In 2012, the price per prescription exceeded $2,500 across all payers. 2012 to 2016 growth ranged from 66% to 93%, with the cost per prescription hovering around $5,000 for all payers in 2016. So that concludes our introduction to the Minnesota APCD prescription drug public use files. For additional information on NDCs and other drug characteristic variables found in these puffs, you can visit the FDA National Drug Code Directory webpage, where puff users can look up additional information in the FDA reference dataset using NDCs found in the detail puff.
Pinar, can I add two more quick points?
Yes.
The first one was, so Aaron made that clear, but the commercial data have gone through real life changes in the sense that, some data from self-insured employers is no longer part of our data system, and we can talk about why and how that is at some point. But so users have to be really mindful of that when they think about interpreting the results. The data lends itself to some uses, but not to others. So that's something you really want to pay attention to in your work. The other thing worth noting is that the data is before rebates. So, for those of you who pay attention to this, you will know that there is a wholesale average cost that is out there or maybe obtainable from various data sources. And so the supply chain then negotiates the price for different elements across the supply chain. The rebate and the extent to which it's passed on is a highly guarded trade secret, so it's not built into our data. So the actual prices, the transaction prices that we're listing here don't capture that. We'd love to take that into consideration, but that data doesn't exist unless something changes in the policy space. So again, something to think about as you structure your analysis and as you think about the inferences that you draw from the data, you want to be mindful of this nature of the data, not so much the limitation. And it looks like
That's a good point, yeah.
looks like we have a number of questions. First question: can users access information on office administered drugs from other PUFs? Currently not. It's a really important question, of course, because this is the space where the greatest increase in prices is, and where the intro price is the highest. It's certainly an area where we all should pay attention to. For the current PUF, we decided not to include that, but it's definitely a consideration for future work.
And it's not publicly available, is it?
Correct.
Okay, because I want to make a little insert here that one of the rules of the challenge is you will be working with the data that will be released by Minnesota Department of Health, which we will release March 18. In addition, you can use any other publicly available data, but part of the competition rules is you cannot use any other proprietary data. So that's why Stefan's team gave us all these links to the FDA website, and sort of if you wanted to link in NDCs to this kind of data, those are publicly available, you can use, but using other proprietary data sets that are not provided with the data release for the competition is not allowed.
Pinar, if somebody, as part of their presentation, sort of sketches out what additional work could be doable with additional linkages, would you consider that as part of the competition? Sort of like how to extend the work?
Yeah, I think that fits in very well as an extension, future work, because I know why you're asking the question, because Stefan's team is very interested in hearing from all of you, and the competition is one mechanism to relay that message in how the value of the data that they're releasing can be enhanced even more. What else can be done? What are some important characteristics that can be added? Yeah, we won't be able to add them by March 18, but you could make that as part of your presentation as to what extensions could make this work even more valuable. Yeah.
There's a second question. Why are the rows redacted based on provider counts, and are provider counts reported? So the way the data use is authorized by the legislature beginning in 2014. So I'll take a little detour here. The data, the APCD was initially authorized so that Minnesota could do comparisons, provider level comparisons on cost and quality in I suppose the primary care space and for hospitals. In 2014, we had reached a point where the provider and health plan, the legislative community, was no longer willing to support that. Clearly, the healthcare space is a business, and I think the reporting on cost and quality at this level is certainly frightening and potentially disruptive. But also there were, some, I think at this point, not founded concerns about the data. Long story short, the legislature asked or directed the health department not to make information on providers available. So the way we the way we structured then the data is to make sure that users cannot directly or indirectly identify healthcare providers. So that's a long story for how why provider accounts are redacted, and we're not reporting provider accounts as part of the public use file. But again, interested in hearing if that's valuable or not, so long as it long term does not become a pathway to identifying providers in the data.
Yeah.
Are there other questions?
Okay.
So maybe one question to Pinar. So the data will become available on the 18th, as will the documentation for the data. If participants have questions that are specific to the data, will you consider? Will you contemplate considering them and offering answers to all participants, or
I think so.
is it here it is and
Well, it's a learning experience. I mean, we view this as a learning experience. So I think what we could do is create a form for questions from the competition website. And through that, you could ask us questions. And at the same time, we could kind of have a live document that has question answer document on the competition website.
Mm-hmm.
Yeah.
Yeah, it might make sense to sort of limit the window, as you say,
Yes.
from the date of the release.
Maybe a week long,
Yep.
1 week long period where you can ask questions about the data, which we would send to you guys.
Yeah, and I think depending on the question, we may wish to answer them, or we may have an answer, or we may prefer not to answer them to make this competition exciting.
So yeah, we're sorry about sort of the little glitches on the slides, but we will make the slides available on the website, and we'll look through the audio quality afterwards for the recording and see if it's absolutely not acceptable. We will try to figure out a way to maybe we could record over or something. Yeah. Well, thank you so much for joining us. And yeah, just let us know if you have any questions, and we hope you will consider joining the competition and encourage others to join as well.